Okay, so this is a continuation on the overview for connective tissue and
We'll call it part 2.
profound statements.
Oh, that's okay. Profound statements about myofascial.
So what I want to do is put these targeted methodologies into perspective with a broader scope of what interventions are. So, we've already established, am I good?
Yeah, you're good.
We've already established that the general massage is the assessment. So, what are the components of a general massage? What do you get them on the table, you got them bolstered right, they're draped correctly. What's one of the first things you do? You touch them. Amazing. All right.
Profound statements.
You touch them, so you make contact. Now, once you have realized that touching them can give you information, then you start to gather or collect that information. So what sorts of kinds of information can you get just with a touch? Hot?
I was going to just say the general temperature.
Okay.
You can kind of see blood flow, like if they have, if they're retaining, when you do the pressure. You can kind of see.
So we've got temperature, we've got at least an idea of surface circulation we can observe while we're touching, so we get color. And we can look to see what the skin integrity is, and we can pick up rhythms, can't we? We can get a sense of how they're breathing. And we can pick up fluid retention as well. So, and then with just a few little variations on the touch, we can pick up connective tissue slide or bind. So there's a lot that happens with that. And we're trying to target initially with the touch the more surface tissue layer. Whoop, that's backwards. Start at the bone here. Okay. So in this model, this is bone, muscle, connective tissue layer. All right, this is skin. So when I am just touching, my focus is there. So how much, as I start to modify this, how much pressure am I going to use? How much downward forces are going to be applied?
Depends on the
Very little. Well, depends on what tissue layer.
Tissue, skin.
Skin, so very little.
Very little. Yeah. Now, what's hard in this is that the skin is very thin and it's very tightly bound to a more fluffy, spongy-like layer just underneath it. So I usually think of the skin superficial fascia as one unit. So, it just, if you're looking at it, when we were doing the exam, I was watching you do level 1, level 2, level 3 pressures, remember that? And I could tell where you were at because I could see what the body was doing. So if you were just starting to dent the skin with the pressure, but the body around wasn't moving, then I would see that as a level 1. And some of you, I said, now back off. That's too much for a level 1, because as soon as you get down to a level 2 and you're starting to affect the muscle layer, then the body will move. Because an applied force does 2 things. It either causes something to move, so a force is a push-pull. So it causes something to move, like if you kick a ball, or it changes the shape of something. Like when you press on something. And we got some fun little toys for you to play with here in a little bit to get a sense of that. So when I wanted you to do the level 2, you're gonna go down a little further, but there's also gonna be that push with it. So if that body was moving while you were doing that, I knew that it was too much for a level 1. Following that? And then level 3 is getting down into the mid layer of muscle. And if you allow movement while you're applying that type of pressure, you lose the downward force. So that's where stabilizing the body area and making the area that where you're applying the methodology doesn't move, just where you've got your pressure. And then we played with something called maximal force, didn't we? And the intent with that is to get down into these deeper tissue layers, which you rarely need to be able to do. And it would be more, at maximal force would almost always be an intervention if you're going down that deep. So the tissues that we're gonna target in this class are in that first layer right to the top of the second layer, but not any deeper. So how much pressure do you think you're gonna deliver with these? Not very much. So that's one of the distinguishing qualities of these approaches, is that the change in shape or the degree of movement you get is targeted to this top right here. So we don't think muscles when we do this. We don't think a whole lot about direction of fiber. We do think about how fluid moves, and we think about how I like to think of the superficial fascia skin as a wetsuit. There's places where it hangs on. We want to think about that so your wetsuit doesn't fall off. But it's doesn't have a distinguishing up and down or back and forth type of a fiber configuration. So when we're doing the general massage, these are things that we start to think about, and your assessment for the target areas we're going to talk about is going to come starting when you put your hands on them. And then it'll take off from there. But it won't be the deeper pressure. Now there are times, yes, that you use more effort, and we'll talk about those. But when we're first getting started, I want you to realize that we're talking about this first layer. Okay, now what else do we do during the general massage? We touch, and then usually what's the next thing? We slide or glide, right? Usually we use a little lotion, right? Now see, my pin's gonna die. I left the top on. So we do that with these methods, slide, glide, but we tend to do them without any lotion. Now, why do we put lotion on? Thank you.
You just keep talking.
Oh, thank you, child. Why do we put lotion? Reduce friction. And when we reduce friction, what do we not have much of? Drag. Both of these methods rely on drag, about moving the surface layer of tissue, not slipping on the surface layer of tissue. If you're going to penetrate down with your force into more of a muscle, fascial, fluid area, then you've got to be able to slide through this top stuff so that you're not getting that discomfort of feeling like somebody's ripping your skin off. But for these methods, you don't want to have lotion, or you need to learn to wipe it off or something. Now, this skin, superficial fascia interface, is tacked down to the muscle layer, the first muscle layer. So that means that when I'm looking at excursion, how far I can get something to slip is only like that far. Not very far. So are we going to do big long strokes when we do this? Probably not. We might do all of those as connecting strokes or to get ourselves back to a spot that we want to do over or something. So we've got some distinguishing qualities now when we think of adapting to target this tissue layer.
Do you think you would use less or more lubricant?
No lubricant. Yeah.
Or very, very little. There have been times when maybe the skin is dry and I'm having a tough time maintaining contact, but less is more on the lotion.
So, it would make sense in the application that we do this assessment before we get a lot of lotion on them. And that doesn't always happen. I mean, I forget. Or if I have used some lubricant on another body area, and then I go to an area that's dry, I still have it on my hand. So, wiping it off helps a lot. And then there are even tricks like using a piece of paper towel so that you can tug that skin superficial fascia, or some sort of silicone. Have you seen silicone pot? Like hot pads, like you're going to lift something off of the stove, or
Basically a flat piece of silicone will stick very good to the skin.
something like this. This is a liner for cupboards. So sometimes you cut a little piece of that, and that can help you tug just the skin back and forth. So little or no lubricant, minimal pressure, short excursions, little, very little. So we're starting to see how we would modify this a little bit, right? And then after we glide during the general massage, what do we do next? Typically we twist it, right? All right, knee, twist, so that kneading, twisting rolls the layers, and it's not a push down, it's more of a lift and twist, so there's a bit of a separation there. And it's a squeezy thing like a sponge. So if we're targeting this wetsuit superficial fascia layer, the big dysfunction that shows up with that is that it's sticky. And you got wedgies in it. And so if you just can't get any better than the wedgie experience, okay, for understanding this. So if you have a wedgie, you push down on it to get rid of it. What do to get rid of a wedgie? You pull. It's a lift, pull kind of an idea. So kneading done in a slow kind of way, thinking I'm separating layers here, can be part of targeting this connective tissue surface layer. And there's a particular method that targets just the superficial fascial layer called skin rolling. It really should be superficial fascia rolling, but you're just lifting that up and you're rolling it. Now, there's fluid everywhere. I mean, we're all fluid. So if we wanted to move fluid from someplace to someplace else, we can squeegee it with a slide glide. Have you ever cleaned your window? All right, you can squeegee it, or you can twist it, like you wring out a cloth or wring out a sponge. And so this kneading, twisty thing also is going to affect fluid content in that local area. You can press on it too, but a twisty action is a little bit more effective, right? Think about a sponge. I can just press on a sponge and I'll get some water extrusion, but if I twist it, I'll get a lot. Okay. Then what do we do? General massage. Luke's giving you a hint.
Joint movement.
All right, so just these things are going to generally address the anatomy and physiology, and kind of just, like if you've got a wrinkly sheet, you just kind of give it a couple of shakes and it straightens out a little bit. And of course, during all of this, we're affecting the autonomic nervous system a lot, and how it carries into the endocrine system and all of that. And you're going to learn with these pressures, these slide and drags and all that kind of stuff, that especially in the surface tissue, we're squeezing out chemicals that are there, histamine and nitric oxide, which are vasodilators. Is that going to affect the fluid movement? Probably. So when we move the joint, you can't help but move fluid. And filtering stations of the lymphatic system, lymph nodes, are primarily located where they're going to get squished on rhythmically. So they're in the neck, and they're in the axilla, and they're in the groin, and they're by the elbows, and they're in the behind the knee, and there are other places too. But it makes sense, right? That, if you're going to move fluid, you pump. There's a rhythmic pump to it.
But it also happens to be places where they will be squeezed. So in your armpits, you bring your arms down. Not only did you pump, but you squeezed those nodes. Same thing at the groin and the back of the knee every time you bend your knee. So your body mechanically uses free energy to move fluid. This is also a big part of, including in the muscles when they are firing as they do movement, how you return blood back to the core of the body. So returning blood and waste fluid back to the core of the body to all be reprocessed is done mainly through some kind of joint movement, which also is going to change the shape of the tissue. If I move a joint, I'm not only changing the shape of the muscles, I'm changing the shape of the superficial fascia and the skin. So every joint movement's creating a little bit of a tension on one side and a shortening on the other. So it's a lot of benefit for the sake of just moving them around.
Okay, NS assessment, we know that. Okay, so then this is pretty much what our assessment aspects of our general massage are. Is that we touch, UCH. We touch, we slide, glide.
Are you using the bad Sharpie?
I don't
Not
know,
the bad
honey.
Sharpie.
I've got 16 of them here.
This one right here.
Welcome to the
Not
real
Sharpie.
classroom.
You don't want Sharpie on the dry erase board.
All right. I forgot what I was going to say. What was I gonna say? Anybody know?
You wrote something about touch on there.
Essentially
Right.
massage.
Okay, thank you very much. So, and essentially that full body massage are these elements over and over and over with a variety of pressures, because we are focusing down deeper into the tissue too, for a variety of reasons. Okay. Assessment. Intervention. I'll start you out with the one that people use the most. They press on it. Now, that's called a lot of different things. I tend to use the word inhibitory pressure because this is more targeting the nervous system. Where you push is usually an area where there are sensory receptors that are checking for length or contraction of muscle tissue or something, and they get confused. Now, that can be called a trigger point. There's controversy around all of that, but it's just because we don't know for sure what it is does not mean it's not a useful concept. These trigger pointy areas lay almost 100% correlation to the acupuncture type areas, and then connect the dots in relationship to how the nerve tracks, the major nerve tracks from the cervical plexus to the brachial plexus to the lumbar plexus, how those track out into the limbs. Those are your meridian pathways. They line right up. The bottom line is there are areas where there's a lot of neural sensing stations there. And it's also, they're called neurovascular bundles. It's also where there is a lot of perforating vessels from the blood and the lymph, the bigger lymph channels, kind of come up and are able to distribute fluid in the more surface areas. So inhibitory pressure. Now, what can I add to inhibitory pressure that would load this area in a different way? Movement. So if I use inhibitory pressure and then I move something, I move it passive, they move it active. Now we're getting multiple loads into that particular area. And the nervous system has got to go, what is going on here? You know, first it's short, now it's long, the spindle cell's going, I don't know what I'm supposed to do. And they give up and they move to a more normal resting tone. That's what we hope. Okay. We can apply shear. Did I spell that right? Friction. So, inhibitory pressure is pretty static. Doesn't mean you can't combine these things. How would I turn a static and inhibitory pressure into a little bit of a shear friction? Oh, just a little one. Yeah, so inhibitory pressure. All right, now it's got a shear component. So the quality of a shear component is translation from one layer to another in one plane. This is essential when we're thinking about connective tissue, superficial fascia movement, and lymphatic drain. The main method we use is, the main force we use is introduction of a shear stress into it.
Because of what your intention is.
Yep.
You want there to be an even slip and slide of that layer on the layer below it.
Now, connective tissues are what we use to heal. So if we have had a little muscle tear, or if somebody has had a surgical procedure where they have had an incision, or you've had a strain or a sprain, what you have is an acute injury, and then your body has a normal healing process that it uses. And it fills up that hole with collagen and some elastin and that sort of thing. We want to call that a scar. That scar needs to be mobile. It can't be stuck to the underlying layer. Now, when they do an abdominal surgery, they cut through all the layers. And not all surgeons are very good about sewing each of those layers separately. Luke's dad was in a really severe car accident a few years ago, and he cracked some vertebrae in his back, and they had to go in there and put a rod and stuff. Now, he was a
And had to do
veterinarian.
it twice.
Yeah,
So,
because there was infection, right?
mhm.
Now, he's a veterinarian, so he was an excellent surgeon. And I was talking to him about it, and he says, well, I would have sewed that up better than what they did. They didn't sew up the fascial layers at all. They just stapled the whole thing together, and that's why I can't move. And he was right. So he always sewed, because I used to help in surgery in an emergency situation. He always sewed each of these fascial layers and muscle layers separately. And didn't glue them either, because when you glue, it's hard to glue each layer too. These are very small, thin layers. So there's a tendency for something like that for a layer to stick to the one underneath it. And you can get an idea of how that feels by just pinning down a piece of your shirt someplace and then trying to move around, and it won't move right there where it's supposed to. It's supposed to move like that. Layers are supposed to slide. Well, now that's a real major compressive based wedgie type of a situation, right?
Now you got a wedgie with super glue.
Ew. And so circulation is interfered with. The nervous system is stimulated in a way that it doesn't understand the messages. Something called mechanotransduction, where a cell tugs another cell, and that sends a message. You ever play telephone? Where I say to you, you know, ba 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 ba, and then you say to you, ba 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 ba, and then you say to you, ba 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 ba.
No, it's completely different.
All right, so then it encounters a scar, and all of a sudden the message then is, okay, you know, it's kind of stuff like that.
And if the area has been chronically inflamed, maybe re-injured, like a kind of perpetuating re-injury or something, then you have that process of inflammation that's been in the area for a long time, so these transmission signals are occurring more and more. And it creates more room for dissonance, just more room for your nervous system to get confused for the sake of confusion.
Now, whoops, I don't think I spelled that right. Inflammation. All right, inflammation is a very important part of healing. And there's a signaling process for connective tissue fibers to the fibroblasts to secrete these fibers that are trying to knit the whole back together. That should resolve as the healing process continues through the subacute phase into the acute phase. But there are situations where you have inflammation without an injury. Can you think of one? Repetitive strain, where you move,
Tennis elbow or
yeah, you move something in there's usually a rub underneath that, and you rub, which is a shear. You rub, what happens? It gets warm. Isn't that a quality of signaling an inflammatory process?
Yeah.
All right, so you start to get this buildup. The connective tissue thinks it's healing a hole. So you start to get this buildup of fibrous, first it's inflammatory, but then it's just wadding. It just becomes this fibrous wad sort of thing.
So simplifying, where there's excessive, maybe not normal rubbing, usually excessive in nature, but maybe the person's loading the joint in such a way that's causing certain structures to come in closer contact. So bursitis, tendinitises are a good example of this for multiple reasons. Maybe there's a structural issue, maybe it's an overuse issue, but the friction creates the inflammation, which then triggers the nervous system.
So we get this, so now we got two ends of the stick here. And we can use a connective tissue-ish type of an approach to try to normalize this. We can modify the location and intensity of this connective tissue gliding, sliding during the healing process to support things healing mobile. Or we can introduce an inflammatory process through frictioning to take a chronic area of fibrosis back to an inflammatory state of fibrositis, create a therapeutic inflammation, take it back to an acute inflammation state, and then support a normal healing process after that. So that's what cross-fiber friction or deep transverse friction is that you get right on a spot and you go back and forth and back and forth and back and forth until there is an inflammatory response.
Now, you wouldn't do that on a recent muscle strain or sprain, right? You wouldn't do that on an acute injury. But if somebody had an old muscle strain or sprain that had built up some excessive connective tissue and or the inflammatory process has perpetuated beyond the acute phase, then maybe you think like that. So if it's a new injury, you do not friction on it.
You
But
use
if it's
shear to keep things sliding.
right, like for example, has anybody had a loved one or yourselves post-surgery? They want them to be grabbing the skin and moving that around and keeping the scar pliable, but you're not going to push too much directly on the scar and aggressively move it back and forth. So supporting pliable scar tissue is incredibly important. But in many cases, we sometimes deal with a situation where a region has not found its way through a healthy resolution in the inflammatory process. It didn't start from the beginning and make its way all the way to the end. It got somewhere stuck in the middle. So when in those chronic situations, using friction, like she's saying, to restart the process and support a healthy resolution can be a reason. Lots of the scraping techniques that are used. Any scraping technique is essentially deep transverse friction. So
this then is targeting localized areas as part of an intervention process as well. So pressure, shear, and then what's another intervention that we have? Lift, elongate. Lift, elongate. Now, this often is thought of as stretching, but many of the issues that we think of as connective tissue focused, or it's nervous system as well in here, the sensory mechanism is on the long axis. And so when I try to, I got a tight shoulder, and I try to stretch it, it's probably not gonna get enough force into those tissues in order to actually change the shape of them. So, if you look at something like yoga or Tai Chi, there's two planes of movement combined. So you'll have something on the frontal plane with a twist, trying to get that kind of torsion into an area like that, or sagittal plane and transverse plane. But if this is localized, it'll feel stiff, you'll feel like you want to stretch it maybe, but you're probably not going to get to it. And the longitudinal stretching, where you really force it to try to get something to let go, is probably going to be too aggressive. It's fine for general flexibility, but in order to get the satisfaction you're after for a sense of relief with that, you're probably going to do too much and you're going to strain the joint.
The best example I have of that is some of the stretches for the hip. Some aspects of the hip, like the abductors, you physically can't really get your hip joint into a position where you would lengthen those tissues and get a satisfactory stretch. So.
And you end up tearing something. I mean, you end up straining things on this longitudinal axis. And so I move everything, but I seldom stretch anything. And I get real nervous about these stretchology, stretch studio things that are propping up all over the place. Because in chronic pain issues, most of the reason for them is hypermobility, not hypomobility.
And static passive stretching really localizes the tension on the tissue nearest to the joints, not in between. It happens mostly because you have to take the joint to an end range to get the stretch, right? So the forces are kind of focalized there. Dynamic stretching is a little bit better, something where a person's up in gravity, like yoga and Tai Chi, when they're moving a little bit through, even some of the muscle energy techniques that we'll look at relate to a person doing some dynamic related movement associated with the stretch. That tends to be not only safer, but more effective.
Now, people confuse stiff with pain or stiff with short, and they try to get rid of stiff. And general flexibility stuff, not aggressive, not past normal end range, which for flexion is 90, for adduction's 45, a little bit more with the shoulder because the scapula moves. Twists are about 45 degrees from anatomical position. But when I see somebody getting their leg around their neck, and then I just go, oh my God. You know, or the hypermobility